All right. Good afternoon, friends. Appreciate you all being here with us today. Going to run through our June coordinators meeting for 2025, which is passing way too quickly. So thank you all for hopping on. I do have a call review for you today. It's been a while since we've done one of those, but I found one that I think has some of our good talking points. And then I have just a couple things for you related to our LMS platform and some ways we can use it with our STARS coordinators. We'll run through our usual metrics to review and then have some tech updates and just a link to our educational opportunities. So without further ado, I thought we'd do a call review. This happened in early May. So this is for one of our kiddos. They called in the afternoon. So, for my EMSers, I'm sure you're thankful you didn't get woken up in the middle of the night. This is for a 5-year-old who weighs 20 kilos, and she was called for an active case of status epilepticus. So this is this kiddo's history from her STARS form. So as you can see, pretty extensive medical history. In fact, a long history of status events, and then also lots of chronic respiratory issues. And then you can see her other past medical history down there at the bottom. Of particular note, she is one of the really complex neuro kids who had an extensive seizure action plan. So this is what mom was following at home, just multiple steps over multiple hours to try and control the SE events. This is obviously just taken from her STARS form for the seizure. She, of course, had all of the tracheostomy warnings and the ventilator warnings. She has a BP shunt and all the typical warnings on that. The other thing of note, a long history of getting into some pretty significant hypoxic issues, either from respiratory illness or just her baseline or because she's seizing. So here's the cruise narrative. So they did respond for the SE. You can kind of see the precipitating event of why mom deviated from just following her plan. She was watching pulse ox sats, and the kid had a significant DSAT event in the middle of the seizure, to the point of mom started bagging herself with oxygen, which was able to raise it a little bit, but only back to 60%. And then mom tossed her back on the home ventilator, but with some increased oxygen. She's normally on 0.5 liters per minute, brought her up to 4 liters per minute on the ventilator, and that increased her SATs closer to 90%. And then you can see EMS noted, that mom's already following this plan and they're on step 3. And then they took a portion of the next step prior to departure where one of the caregivers, either mom or the home health nurse, gave a dose of Keppra via G-tube. And then they also were treating the fever just to kind of rule out febrile seizures and to treat the fever. So, anyways, they did transport. Just a couple things I'll call attention to them later as well. But just some good documentation and just good general care of escalated oxygen until they got the SATs under control. And then you can see they tried to back off, kind of in accordance with talking with mom and saying like, hey, we'd really not like not to be on 10 liters if at all possible. But they kept watching the patient, and she, of course, immediately started to desat. So they flipped it around and took her back up to 94%. So some excellent documentation on that, and just general good practice. Just another case of this kiddo was 19 miles away, bypassed 2 other adult facilities to bring her directly to her children's hospital, which we're always appreciative of and think is a good idea. So just some wins from this call for sure. Especially in different parts of my career, like I don't know that I would have been able to like walk into a season kid and been like, no, I absolutely have my other protocol I have to follow. But they were able to say like, listen, mom's dealt with this before. This is the plan to address the seizures, and they followed along with that. The oxygen management is already called attention to, and the directed tertiary. So definitely just a good, well-run call, and the crew did an excellent job on that. I cannot always depart from my old medical training coordinator ways, so I do have to always just highlight some room for improvement, even from a well-run call. Um, We still continue to see on the kids unable to obtain blood pressure. That's true sometimes, but a lot of times, if a 5-year-old, where there's a will, there's a way. I think it's still pretty good practice, for a kid who is pretty. I think we can all agree, sick with bad vital signs. Um, Probably should still try to get a blood pressure or at least a little more documentation as to why you were unable to get one, especially for a kid who's actively seizing in the back of your truck and is headed for the PICU. And then the other thing, just anytime any of your crew members are transporting somebody on a trach, always a good idea to still go ahead and get that entitle spot check just to make sure that we are ventilating well, and just to have that number in place. We, of course, kind of encourage as just best practice to watch entitle for the entire trip, while you have the kid under your care. But I would certainly understand, if you just want to spot check it, especially for the little neos. I understand the reasoning behind that. So just a little room for improvement there. I will note on just kind of a sad note on this case. This patient did ultimately pass in the PICU. The seizures were probably exacerbated by a pretty significant case of pneumonia, and ultimately hypoxic respiratory failure, unable to wean. And so it's, a sad case. Like I said, the crew did an awesome job. There was nothing they could have really done different to affect the outcome. But no, I think just another chance to also highlight, like, these kids are, really significantly sick at their baseline, right? Like, sometimes these patients, were treating them in emergencies as if they were, already at the top of Everest at a hypoxic level, and it really does not take much to get them in a world of hurt. And so, just having a recent experience of reading, another note where they're like, "Oh, the kid's not that sick." These kids tend to be pretty brittle at baseline, and to really have a strong sensitivity to that. Melanie, I think you had your hand up.
Yeah. Are you finished talking through that?
Sorry, what was that, Melanie?
All right, let me change my. Can you hear me or no?
I can hear you.
Okay. I was going just to add on to your entitled CO2 with the note that if you're checking an entitled CO2 on a trach kid, you have to do it through the tracheostomy and not through a nasal cannula, because they won't be breathing through their nose, so it will not pick up through their nose. We have had a case recently that was documented that they tried a nasal cannula entitled for a trach patient, and noted that the patient did not breathe through the nose, so the entitled did not pick up. That is obviously correct because they're breathing through their trach in their neck. So if you're doing an entitled check, on a trach kid, make sure you're doing it through the trach and not anywhere else.
Excellent point. Just while I'm on it, were there any questions or additional thoughts on the call for this patient?
Hey, Melanie. Sorry, just unmute myself. Can you guys hear me?
Yes, sir.
Yeah,
Yes.
That's Steve Laffey. Hey, Melanie, just to clarify, does that work even if they're not being ventilated? I mean, we're very used to having the end tidal between the vent and the trach. But if they just have a trach and nothing else, and you hook the end tidal up the same connector there that you would have it on a vent, will that still work?
Yes, because you're still breathing through it, or they're still breathing through it. So yeah, you can use it. Well, just have nothing at the end, ambu bag at the end, or the ventilator circuit or oxygen through it. So yeah, you can use it for any modality of breathing through the trach.
Which would be potentially really helpful if you're having, maybe you don't have a completely plugged trach, but you've got, partially you're seeing some air movement, but you hook up that CO2 and it's super high or whatever. I could see that being super helpful information, actually. And to be honest with you, it's just not something that I've thought about it makes perfect sense, but it's just not something that has popped into my mind as far as the non-ventilated kids. We always, we always think of it, you put them on the vent, you have them on CO2 no matter what. But,
Right.
we should, something to have on just about everybody. I'm a huge end title guy for sure.
I mean, I should verify this statement, but as far as thinking it through, like I think all the Legos should work together that like whatever devices they have on the outside of the tray should fit on the outside of the end title as well, right? Like if they have a passing mirror valve or an HME out there. So even for just transport of the non-ventilated, I would think, you can just add in whatever other thing they have. Next, obviously, as long as they're not in huge respiratory distress, at which point, for all of those who've taken my class, you should take everything off. But I would think just like safe transport for your standard trach patient, if you want to watch them, that would be a good way to do it for the non-ventids.
Yeah, all the respiratory pieces are they do fit on just like they would on an end title. They fit on a trach just the same. You might have to put the end title inline cannula, or not cannula, but inline piece, and then the next piece, like the HME or the passing mirror or the oxygen or the vent. But the end title piece will probably go directly off the trach.
Cool. Good talk. For my STARS coordinators at my agencies, I did want to bring up, we brought up the LMS a couple times recently, but I'm not sure everybody's been around for when we used to talk about the institutions as well. This is not automatically turned on in the LMS for your agency, but it is a feature that's available for your agencies, as far as if you want either a training officer or your STARS coordinator to have a little more control over your users from your agency taking courses, knowing if they're taking courses, being able to assign courses, all of that's available. We actually have most of your agencies already plugged in as options. They're just called institutions within the LMS, as I continue to use lots of different names to describe the same thing. But you can see like we already have users in for different agencies. One of the advantages of that, like I said, is you can designate a coordinator, usually the STARS coordinator, who can have a little more control, and then we can turn on whether you can add users, disable users, you can assign courses, which is learning path selection. But these are all things that are possibilities within the LMS. So if you want to use our STARS education as a monthly requirement, or just, hey, annually, or your new hires, we need you guys to go in and take this, you have the ability to see reports and see, okay, 36 of our users were assigned that, how many of them actually went and took the course. So that's just a way we can work with you, as far as using our LMS to further the STARS education at your local service. So just wanted to make sure everybody was aware of that. I have a few who use it a lot, and then a lot of agencies who just kind of let it default to, if somebody signs up to take it, cool, but they don't have anybody in charge of it. And I just wanted to make sure everybody knew that was a possibility. This is actually true for my ED staff on here as well. The only challenge is that this is only currently offers EMS CEs. We don't have any nursing CEs available through the LMS at this time. Cool. And just to run through a few of our numbers, we added 24 kids since we had our last meeting. So just the forever growth. Kudos to a couple new agencies who snuck their way to the top of the list here. So kudos to Washington County, and in addition to Central County 911 and Collinsville getting up there. Did have 47 dispatches for the month of May. And then reasons for getting in, still kind of hovering similar numbers. We dropped just a little bit on emergency treatment and education, but made up the extra numbers with care plan updates. So definitely have seen lots of new faces getting in. So I'm appreciative of all the hard work people who are getting in to use this for the kids in their area. Reasons for your 911 calls. So you can see, whoops, I grabbed the wrong graph there. But if you would like to review February's dates and numbers, there you go. My bad. I'll email out the new ones. And then this was for calls for May. So there you go. This is the 911 transport calls. So we had 42 that we knew of for May, and then 3 non-transports. And then there's your reasons for the calls there across. EMS did intubate one of the kiddos. It was a full-on DAI. That was actually a Florida call. I'll quickly see if anybody's on from Florida, but it was, I will say, I almost pulled that for some documentation just for standard good EMS care. But something I've noticed a lot more recently is the intubation timeout actually being documented really well in different trip sheets. And they did the stop. Is this warranted? Yes. What are we going to, what are the appropriate drugs for it? What's the appropriate dose for those drugs? And documented a really good innovation process. Did see 4 trachs managed. All of those were with suctioning for the month. There were no emergency trach changes. And then you can see just some of the medications that were given. I will say the dexamethasone, I think we covered this a little bit last month, but that is an adrenal crisis prone kiddo. EMS went back-to-back months on him. And family, it turns out from that call, family was out of his emergency medication. So they were able to document that, and we reported that to his clinical team. Average of 3 days for MD care plan approval. So we do have a lot more of you tagged in those nowadays, so you see if they're going to your doc. But just know that we're also following that up with emails to the medical directors if they're languishing out there too long. But it certainly would be helpful just in case it's going to spam, just in case your medical director is not seeing it. If it's been sitting out there long enough for the week-long reminder, if you don't mind nudging them a little bit just to make sure that they're aware, it would be greatly appreciated. Just as far as upcoming website changes, there's a few more than this going on, but we're in the stage of the year where we have to upgrade all the things in the background that the internet engineers understand that I don't, of updating some of our software. Main things that will potentially affect those of you out in the field, for those of you receiving and sending dispatches. We did run into a few errors with the update where you can select either whole agencies or individual agencies. We're going to try and tweak that screen to try and avoid some of those or to make it more clear what you're supposed to do. The other thing we're going to do is we did create a quick reference sheet to help the dispatch agencies. And we're going to be emailing this out next week to all of the dispatch agencies so that they can, hang it somewhere on the call floor, just so a quick visual reminder of how to do it and what you achieve by clicking different buttons within there. So we'll work on solving that issue. If you do have that happen at your agency, please feel free to reach out to me. That's kind of how we knew. We had 2 different places say, hey, we're having this issue. And that's how we knew, like, hey, we need to do something about this. So please let me know if you encounter that anywhere. I will leave it up on this one last, but if you need any STARS education or you'd like any STARS education from our team, we have it set up now to where you can request that through forms with the Glennon outreach team. So please feel free to sign up for anything, or if you'd like us to come out, we'd be happy to get some more training out there into the world. That is everything that I had prepared for today, but I'm happy to leave a few minutes here if anybody has anything for open session. All right. Will I get more buy-in if I stop the recording?